We're going to demonstrate a posterolateral corner reconstruction using the ConMed exoshape system. We can achieve aperture fixation at all locations. On the knee, we make a curvy linear incision that allows us to get access to the epicondyle here as well as the fibula here. Once the peroneal nerve is identified, wrapping around the neck of the fibula, we need to tag it and protect it throughout the remainder of the case. We put the knee in extension and we make a longitudinal incision right over the palpable epicondyle. Distal to the epicondyle is the insertion of the popliteus. So we want to create the insertion of the popliteus, and then proximal and a little bit more anterior is the lateral collateral ligament. So I make a longitudinal incision slightly oblique, then I elevate the soft tissue off posteriorly and off anteriorly. That way, whatever structures are left that are healthy, I can, once I've done my repair, I can sew them back over to create tension in that ligament. If you use an 11 construct, then you can spread the distance between the proximal aspect of the LCL and the popliteus insertion. So I direct this slightly anterior so that I'm not going to interfere with my ACL tunnel. Now I want to go to a depth of 30 millimeters. So I've elevated the gastroc away from the joint line posteriorly, and I've dissected the soft tissue structures so I can palpate the posterior aspect of the knee. So I want to be about 2 centimeters below the joint line, right in the central portion of the posterior aspect of the lateral tibial plateau. And I'm going to place a guide pin from anterior tibia to that point. If I stay relatively horizontal with my posterolateral corner reconstruction in my tibial tunnel, I will not interfere with my more oblique tunnels for my ACL and PCL. I remove my finger when I'm about ready to go through the cortex, and then I put my finger back in after I've gone through the cortex to make sure I'm in the right position. I've hit exactly where I want to be. So you can see that guide pin. So we're going to ream with an 8 millimeter reamer, relatively close to the joint surface, about 2 centimeters away. Now we want to place a passing suture that we'll later use to pull the graft. So we've created our tibial tunnel and our femoral tunnel. Now we have to create our fibular tunnel. Now the LCL comes from proximal and slightly anterior to the epicondyle. It passes deep to the iliotibial band, and then it enters the anterior lateral aspect of the fibula. So I want my LCL graft to come into the anterior lateral aspect of the fibula. So I'm going to place a guide pin from anterior lateral to posterior medial, midway between the lateral and medial cortex of the fibula. And we're going to fixate the LCL at that point with a tenolok screw. The tenolok is 5 millimeters, and we're drilling a 6 millimeter tunnel. Now we take the suture that we've previously passed through the tibia and we pass it through the fibular tunnel. This is the ConMed femoral exoshape device. Our graft is going to go through this hole right here, and then when this deploys, this whole mechanism contracts, and these two wings spread out this way against the tunnel, and then the block lock wings spread out against the tendon and lock the tendon against the tunnel. And I want to pass one end in one direction, and then I want to pass the other in the opposite direction. And then I want to cleat this construct so that the tails, the shorter tails, are about 30 millimeters. And I've got my semi-T to recreate the popliteus, and then I've got my gracilis to recreate the LCL. I need to rotate the semi-T into the right position, distal and slightly posterior to the epicondyle, and the LCL is proximal and slightly anterior to the epicondyle. So I want to mark this at 25 millimeters, and I've drilled a 30 millimeter tunnel, and I mallet it into place. Then I need to unhook the handle to allow me to insert the implant. I put a compressive force as I insert this, squeeze the trigger, and as soon as I hear that lock, I know that my device is deployed. Now I can uncleat my tendons, and to remove the insertion device from the implant, I slide this blue handle forward and I unscrew this. So I want to pass my popliteus more posterior in the back of the knee, and I do that by creating a tunnel deep to the iliotibial band, deliver my clamp into the wound, and deliver it into the posterior aspect of the knee like this. Now it's ready for passage into the tibial tunnel. Now I do the same thing for my LCL. Now the LCL is more superficial to the popliteus, and then I've already placed a passing suture in the fibula, so I can now pass this. Now I'm ready to pass both of these into the posterior aspect of the knee and then out through the tibial tunnel. To increase the stiffness of this construct, I like to fixate it within the fibular tunnel, and we're going to use a 5mm tenolok to perform that. I want to get rid of the creep of the soft tissue before my fixation by putting tension on both strands and then cycling the knee through a full range of motion. Then I will place tension as I'm doing my fixation. During the fixation of the lateral collateral ligament, which is what I'm going to fix by fixing the fibula, I place the knee in slight valgus. This device usually comes with a loop, but we've cut the loop off, and then we insert this into the tunnel. We insert right down to the laser line, and we turn until we hear an audible click like that. So now we've recreated the lateral collateral ligament, and the patient is now stable and varus at 30 degrees of flexion. Now we're going to recreate the fixation on the tibia. Put the tibia in slight internal rotation. We've elevated the MCL off of the bone here. Now I could also put this tunnel right here as well. I'll usually go 3 centimeters off the anterior joint line and direct slightly superior during the drilling. So we've created an 8mm tunnel, so we're going to start with a 6mm dilator. If you dilate the tibial tunnel, you're going to get an increased pull-out strength resulting from compressing the cancellous bone against the wall. There's markings on these devices. That's 30mm in depth. The implant's 30mm, so I'll usually go to +5. And again, I'm keeping tension on the graft. I want to dilate up to a point where I cannot twist with 2 fingers within the tunnel, and I'm at that point here. So I remove this, and the 8 tells me I need an 8mm implant. These are color coded. It's obliquely oriented, and you need to place this portion anteriorly and this portion posteriorly. And when you place it on the implant, make sure that it's seated correctly like that. So I insert this between my 2 tendons, and I insert down to a +5. Then I remove the insertion device. The implant stays in place. I keep tension on the graft. I slide the bullet down. The bullet is going to be deployed into the sheath. Put this on the back side of my gun and lock it down. And I squeeze the trigger to deploy the bullet into the sheath. Then I remove the gun. And then to remove this, we just simply twist it, and it'll disengage from the implant itself. And then we can cut our tendons at the tunnel entrance point. We have a completed posterior lateral corner reconstruction. So we've created a very stiff construct, and we have more than adequate fixation strength.